Good day, everyone. Welcome to today's APSC CME education series. Today is a quite exciting day for me because it's the first time we are introducing the next generation of OCT champions to compete on the OCT case sharing competition among fellows across the Asia Pacific. The date stamp today is the 25th February 2022, 5:30 p.m. Singapore time. This event is organized by the APSC, endorsed by the Singapore Cardiac Society, APSC, TCIP, CME accredited by EBAC in collaboration with Abbott. My name is Jack, your chair for today, the immediate past president for the APSC, as well as the ICP. With me, my co-chair is Professor Takashi Kubo, a good friend of mine from Wakayama Medical University, Japan. We are also very privileged to have Professor Giulio from Bergamo, Italy, to deliver our opening lecture on OCT, practical tips and tricks. We call him affectionately by Dr. G, so most of us use that as an affectionate term. The format will be 6 to 7 presenters, starting in alphabetical country order: Australia, Dr. Rashid, who's going to present to us OCT-guided Zabo procedure. His expert commenter will be Professor Adrian Low from Singapore. Our second presenter is Dr. Nanda from Indonesia, presenting on utilization of Saline in OCT-guided PCI. His expert panelist commenter is Professor Natterwood from Thailand. Third presenter is Dr. Dian Munawar from Indonesia, presenting on sequential crush in decay crush technique using OCT. Her expert commenter is Dr. Alan Chan from Hong Kong. Our fourth presenter is Dr. Lee from Malaysia. He's going to talk about trouble in paradise, and his expert panelist commenter is Donnie Furman from Indonesia, Harapan kita. Our fifth presenter is Dr. Guagliumi from Singapore, talking about unusual OCT images in SCAD. And his expert commenter is Professor Takashi Kubo from Japan. Our next presenter is Dr. Liu from Taiwan, talking about the 5 years OCT follow-up of a BVS stents. And his expert commenter is Dr. Sydney Low from Australia. Last but not least, we have Dr. Sakawat from Thailand, and he's going to talk to us about OCT-guided PCI of a calcified lesion with a large luminal diameter. His expert commentator will be Professor G. Just talking about the judging criteria that we put our presenters through, we want to demonstrate the utilization of the MLD max algorithm to guide OCT runs and illustrate teaching points. We want to show good quality images and perhaps complexity of the case. We want to show how OCT actually influence treatment decisions. And we want our fellows to put out interesting points or great teaching values and be creative in your presentations. A pitch for upcoming webinars: 28 February, we have an APSC Journal Club on SGLT2 inhibition in diabetes and heart failure therapy. 3rd of March, we have a next series of APSC Fellows Teaching Save a Life series on unusual causes and complications of ACS. A disclaimer: this webinar is copyrighted by the APSC. The views are that of the faculty and do not necessarily represent either APSC. The webinar is currently made live stream via Wonder, APSC Facebook, as well as YouTube pages. CME points will be submitted to those who are connected throughout the full duration of this Zoom webinar. You will then receive your certificate of attendance upon completing a survey sent by email. If you have any questions, feel free to key in your question into the Q&A boxes. So let's get started, and I'd like to welcome Prof. G to talk to us on the practical tips and tricks of using OCT. Prof. G, please.
Thank you very much for hosting me. It's really an honor to go into some suggestion about how do you use OCT and what tips do you have to help other people to get most out of the technology. Here is the first point that I like to address. High quality is still a must. Why high quality is still a must? Easy, because if you cannot see the images, you cannot see clearly the images, especially rightly explain when you are using algorithm. The more we are switching to the automatic algorithm in terms of interpretation measurements, the more we need high quality images. Otherwise, the software are going to be crazy. And this is for all the type of interpretation, not only the morphology, but especially the quantification at the different time points. So the high quality of imaging remain a must. In addition, we have to get high quality of imaging, limited the amount of contrast during baseline angiography. Do not do 1, 2, 3, 4, 5 different views, but when you have the right view already defined, you with one single pullback, you have almost the information that you needed to have in 360 degree. So the first limitation of the contrast is starting from the beginning. Second, maximize the information based upon the OCT catheter pullback and the length of the pullback. Here you have 3 examples: wrong catheter placement, right catheter placement, but short pullback, right catheter placement engaging only a minimum part of the entire longitudinal view with almost all vessels clearly displayed. This is another very important information. Select the best view for co-registration since the beginning, and then do not change during the procedure. You keep the same when you have selected across the entire procedure, at the baseline as well at the final. In this way, you can benefit the most of the angio co-registration. What about tricky situation, challenging situation? Well, we know very well that when you have a banded ostium of the circ, perhaps sometimes it's going to be challenging to bring down the catheter. So many solutions were developed during these years. One of the solutions is to be supported and to have insight from OCT, also having a small support as the ones guaranteed by the guideline. Here you can see one case of the banded ostial circ and how you might solve. Here you can see also the imaging that you can obtain through the guideline as were written. Here you have one video showing that with this trick, you can get all type of information outside, but also inside the guideline without losing any type of additional value. Use the full spectrum of data made available by OCT to decide. What is the full spectrum? Well, of course, you needed to know about the plaque you are confronting, and then make your choice in terms of strategy based upon this criteria. But this is not the only one. You need to have in a few seconds clearly detected all the characteristics of all the vessels, including the lesion lengths, including also the reference diameter. They are not only the ones expressed by the automatic lumen detection area, but perhaps might be also the ones that you calculate manually or based upon the last release version of the software at the level of the EL. So you can understand the type of plaque and all of these measurements to decide in which way to go in terms of strategy. Of course, you needed to decide exactly where to land, how you are deciding where to land, based upon also co-registration. This was recently proved by a script of Dr. Kubo, where you can see the value of the co-registration in avoiding to land your stent at the level of the lipid segment, where you might be much more in trouble in follow-up due to restenosis or plaque evolution. Very important. Try to get, in the vast majority of the cases, EEL if it is possible. This is the last software release where beside the automatic lumen detection border, you might see also the EEL calculated, each frame by each frame. Why and when is important. And especially important when you have this type of lumen detection, when you have a diffuse disease with a multiple section, is so difficult to understand the size of the vessel. In this case, it's enough to have a few sections or one section on the way where you can see the EEL and you can measure the EL to see the big difference between the measure done by the lumen, because you have full of pathology along the vessel compared to the EL, and then guiding with more precision your procedure. I'm so happy to have somebody today presented from this center. This center was acquired in a co-sharing in Indonesia, is one of the example of the dual CTO. Here you might see the dual images and then the strategy to reopen the vessel. And then you might see the message in terms of tips that we can get. When you are reopening a CTO after a longer period of time, number one, when the vessel is reopened, but with a limited flow, don't go immediately for imaging. Otherwise, it is so difficult to get information about the size of the vessel. Instead, you need to try to pre-deal a little bit more aggressively. But if it's still not enough, and if you are concentrated only on the segment of the culprit lesion, including the landing zone, the vessel is still very restricted, and perhaps you don't have the right measure. Then take your time. Don't watch only to the area for landing around the culprit lesion, but go across all the entire segment of the vessel just to reopen. And here you can benefit of the difference in terms of a size and correctly size your procedure. And this is the final results in this complex procedure using the 3D. What about the calcium? Well, dealing with the calcium at the multiple time points, because we are asking the people to do baseline after pre-dilation to check the results of what we did, perhaps after optimization of the lesion preparation, and then after the stent is based upon only one thing. We need a nice catheter for being more trackable into the lesion and to be more resistant to allow to finish this complex procedure. Calcium detection and quantification, we know that there are some recent advantages, and the recent advantages are many in the quantification and automatic quantification. You have simultaneously display in orange the segment with the larger calcifications on the top of your co-register imaging, and then you have a segment by segment the quantification of the arc and of the thickness. So if you can take the advantage of this aspect. So for treating calcification, you need to have to look to the baseline, and then based upon the characteristic of the calcium in terms of nodularity, circumferential, and all these things, you are deciding the strategy, but very, very important. You needed to check on the way the effect of your strategy. If you are using something for cracking, dissection, you need to detect this before going to the stent for maximize the results. Very different response you might have in the same patient due to the different type of calcification. Sometimes it's not enough to get the evidence of a fracturing in some segment, other segment can do differently. So very, very important to be aware of that. What about the bifurcation? In bifurcations, the online 3D might be particular value in identifying the stent cell after rewiring the side branch. Very, very important. OCT evaluation of the wire position is useful when balloons cannot be advanced in a jail branch. Especially use OCT in this case when you wanted to unravel issue prior to the stent implantation. Here, one example, patient coming with an anterior myocardial infarction, subocclusive lesion on the LAD, plus some severe stenosis on the circ. So you approach the LAD, and then perhaps you stage the patient back for finishing the procedure at a distance on the circ. And then when the patient is back, beautiful results on the LAD, but trouble in getting with the balloon down to the circ, don't hesitate. Go to the LAD and try to get the evidence of what is going on. Here you can see the protrusion of the stent implanted into the LAD into the left main. Here you may see the 3D images showing the fact that you are in trouble in crossing because there was some suboptimal non-intentional results, and then you take advantage of this for recrossing in a very proximal part, and then to change the strategy. Here you can see stage V-stenting, and then you check the situation at the end in terms of a final results with a long OCT and by using the best that you can with the 3D. Get out from trouble with imaging. Don't wait too long. Use from the beginning in unclear case. Here you have patients who had a lateral MI and one stent implanted in D1 many years ago. He was AF in anticoagulant therapy. He had multiple bleedings. The therapy was changed, and he had recurrent asthenia. And everybody was thinking about the antiplatelet therapy. And he did multiple angio with no so significant evidence of what was going on. Then when received the patients, quick pull back in the LAD. Here you can see what was then at the level of D1 and the reason of the thrombosis. If you are brave, you can try very carefully to go inside this branch to have an additional evidence and perhaps to fix. Very, very important. When you are doing one procedure, have a look at what is going on into the lumen. When you started to see thrombi, you needed to react immediately. Here you can see the evidence of what is going on when thrombus is forming during a PCI, not only inside the stents where you have struts, but also outside where you have some plaque. The thrombus is forming everywhere. You need to react immediately in terms of drugs. Perhaps here you might see small molecules used, and perhaps with stent optimization, here you might see the effect in thrombus removal of a post-dilation with a larger balloon. Very important when the patient is coming with clot forming, stent thrombosis. Many times you have multiple mechanisms involved you can detect by OCT, but you needed to distinguish among them the ones that is the dominant mechanism, normally by using where the thrombus is sitting compared to the bystander, likewise this longer term malposition. And I think that if we finish the time, we can stop here. Very important Do not trust on the amount of procedure you have done. When a patient is coming with multi-vessel and a challenging situation, many people, they are not a believer. They are starting doing very complex procedure, LAD stenting, then they are switching, going to the circ stenting, and then the patient is starting to get into the problems, symptoms plus ST changes, and then you go ahead if you are maniac about the angio. In this case, the procedure was using an additional implant in the intermediate, but the pain did not change, the SCT did not change. They started using morphine, epinephrine, and then at the end, when it was quite late, they finally called for help. Short time, just one pullback inside the left main. Here you can see the ostium of the LAD plus the thrombus forming. You don't need to be very sophisticated for understanding thrombus and for understanding the original rupture plaque that was causing the problem. So at this point, you are quickly fixing the situation with drugs and final intervention, and this is the final results. So my last message is don't wait to get CK very high to use imaging when you have something challenging and something that can benefit for a clear understanding and a clear plan. Thank you very much for listening.
Thanks, Dr. G. Very comprehensive tips and tricks and illustrative cases. I'd like to now invite Professor Kubo to comment on the lecture first. Thanks, Takashi.
Thank you very much, Dr. Giulio, for giving us a very, very elegant lecture. It's very educative. I have 3 questions, simple questions. Number 1, how many percentage do you use OCT during PCI for your daily clinical practice? Number 2, when you determine the stent size, do you use a EEL rather than lumen? Number 3, which is bigger in the stent diameter selected between OCT guided versus angio guided?
Okay, as usually, very challenging question, but very appropriate. The first one is everywhere OCT is underused because you have a fan and you have opponents. And I think that there are clear settings where we must use. The more is the complexity, the more is the challenging, the more you can learn. The second way is the ones we are doing today. Thank you very much, Jack 10, to organize this championship race, because we need to teach the younger person since the beginning about the advantage. Don't wait too much in age for teaching them and for making them passionate. So very, very great initiative. Second point, we use both because both are telling you the lumen and the EL. The more plaque you have, the more is increasing the gap between lumen and EL. And so you know the maximum that is represented by the EL, and you know how is the lumen. And so you can decide more appropriately. The last question was about the sizing. When you are using OCT, you are becoming extremely more sensitive in angio. My people say that normally I'm upsizing the stent 0.5. Means that your mind and your vision is started to get also the best when you are not using. And I think they are the main messages to leave to the younger person. Thank you very much for the comment.
Thanks both. Sydney, your last comment before we move on.
I was going to make a very brief comment. Wonderful talk. And I think you focused on the basics for the beginners because the images you show are beautiful. And I think that if you follow all the rules and then all the preparation, guiding catheter engagement, you'll get beautiful images such as the ones you've shown us. And so many applications before, during, and post-PCI, particularly the calcification and the adequacy of your plaque modification to allow PCI for optimum results. And of course, I think these automatic measurements are very useful and they're so beautiful. The identification, the resolution of the OCT is so good. You can identify the problem, the culprit plaques, the TICFAs, and of course, the comfort level at which you can post-dilate and the sizing, which is very pinnacle in getting an excellent stent expansion. So I think that is the thing. I find that using OCT, we have less stent edge dissection because you're sizing better. And then if you're doing all of that, you minimize the number of pullbacks you would do. And I think that I really enjoyed that talk. It was wonderful, wonderful demonstration.
Thanks, Sydney. Now I would like to welcome our roll call of gladiators. Starting from Australia, we have Rashid to present the first case.
Hi, hello everyone. Can I just confirm that you can see my slides here?
Yeah, please go ahead.
Perfect. Hi, I'm Dr. Rashid from Monash Heart in Melbourne, Australia, and I'd like to share a case that I found OCT to be very helpful in terms of planning for the case and also assessing the PCI procedure. So I would like to present. I'm happy to present an OCT-guided Zabo procedure. So I'd like to present Mr. CM, who is a 68-year-old gentleman who presented to our hospital for an elective PCI for ongoing CCS class 3 angina on a background history of type 2 diabetes and dyslipidemia. As you can see here, he was already on 3 anti-anginal therapy. He was on atenolol, amlodipine, and isosorbate mononitrate by the time that he arrived to our cath lab. His story actually started off with ongoing symptoms. I presented to an external hospital and had a CTCA that demonstrated possible osteo-LAD disease. There were some issues with the CT acquisition at that center and a subsequent nuclear perfusion test confirming LAD territory ischemia. In view of the ischemia trial, he was managed medically initially and had ramping up symptoms and subsequently was referred for an angiogram at an external hospital. And in this angiogram, he had quite an angulated heart. So these were quite extreme angles. So this is an extreme LAD AP cranial view. And you can see here that the left main is a long and large vessel that essentially trifurcates into 3 big vessels here. You've got the circumflex at 12 o'clock, a big ramus system at 3 o'clock, and then this kind of like dual LAD system at 5 and 6 o'clock. And you can appreciate here the ostium of the LAD. There is some significant haziness in this vessel. And the image on the right is the spider view, which was quite angulated as well. And you can appreciate it. There's quite poor imaging, but also there is a suspicion of some disease at the ostium of the LAD. Therefore, he was treated initially with medical therapy and subsequently had ongoing symptoms and returned for an elective PCI. We had a right radial approach with an EBU 3.5 guide and a Sion blue guide wires into the ramus and the LAD. And initially what we wanted to do was to have a look at fully appreciate the lesion here. And what we could see here, and this is from the left main itself, it's a very large left main, roughly around almost 6 millimeters. And you can appreciate here the ostium of the LAD. There is a calcified nodule with the minimum luminal area of 1.2 millimeters. And you can also later on appreciate that there is quite a mixed plaque, but some areas that did have almost 180 degrees of calcium, such as this area. But the whole LAD actually had quite significant plaque throughout. So using the MLAD max mnemonic, so the morphology here, as we can appreciate the calcified nodule and some areas of calcified proximal LAD, which means that we probably need some plaque modification. With regards to length, we know that there was a significant mismatch in the left main and the proximal LAD. Therefore, our aim here was try to avoid landing the stent more protruding into the left main or missing the ostium of the LAD itself being too deep into the LAD. So that would be another catastrophic issue as well. Therefore, we wanted to land the stent just at the ostium of the LAD. And looking at the images that we had previously, we thought that in order to cover most of the calcified plaque. We didn't want, so most of the plaque we didn't want to land into a heavily plaqued area. We decided a length of roughly 32 millimeters would have been quite suitable. And with regards to diameter, there is a lumen of 2.3 and E of 2.6. So we thought a 2.5 millimeter stent just at the distal end would be suitable. An proximal reference was a bit difficult, obviously due to the eccentricity of that vessel and the calcified nodule, but we thought it was roughly around 3 millimeters. So in order for us to land this stent, and as I said, there was some catastrophic, some potential complications if we missed the ostium of the LAD, either being too deep or too protruding into the left main, we decided that we did require a technique, and this technique to land the stent at the ostium of the LAD, and this is the Zabo technique, which you can see in the video here, involves 2 wires, one into the lesion itself, that will be where the stent will be delivered, and another wire that acts as an anchor, which is essentially wide through the most proximal portion of the stent. And this is performed before delivery of the stent, where the sheath that's covering the stent is partially withdrawn to expose the proximal part of the stent. The balloon is then inflated. In this case, we inflated to form atmospheres, and you can see there is flaring of this of the proximal part of the stent. The balloon is then deflated, and then the wire from the ramus is then wired through, and that acts as the anchor wire. We thought that delivering a long 32 millimeter stent in an angulated vessel would be quite tricky, so therefore we decided 2 separate stents. And in terms of plaque modification, we thought a 2.5 millimeter non-compliant balloon was sufficient. As you can see here, we did that first, and then subsequently we delivered 2 separate stents. So we delivered a 2.5 by 20 millimeter synergy, which initially was quite difficult, probably due to the angulation. So we required another body wire into the septal. And this was delivered, and then subsequently we delivered a 2.75 by 16 millimeter synergy stent. And then using the earlier measurements that we had, we sequentially post-dilated the stent with a 275 and then a 30 in the more proximal area, and then a 325 in the ostium of the LAD. And this is the PCI that we perform, the OCT we perform after the PCI itself. And you can appreciate here that as part of the MLD max mnemonic, that there were no medial dissection at the edge of the stent. And we can also appreciate that there was good apposition throughout the stent. Firstly, as we can appreciate, the indicator here is white, suggesting there is no gross malposition, but also visually, we can appreciate that the stent's quite well posed. And importantly, the stent expansion here was 90%, which was very acceptable. Also, the other benefit of having the OCT here was to also detect the location of the most proximal strut. And here you can actually use the 3D navigation of the bifurcation view, and you can appreciate that there's just a single strut into the left main, and that which essentially confirms the position of the stent with the Zabo procedure. So this is the final angiographic result. So in summary, we performed a elective PCI in a 68-year-old gentleman with stable CCS class 3 symptoms with OCT guidance PCI to his ostroproximal LAD using the Zabo procedure with 2 separate stents and subsequently post-dilated up to a 32.5 millimeter approximately. Thank you all for your time.
That was a great talk, Dr. Rashid. If I may just make a few brief comments. I think to what you have shown is a nice illustration of a technique that may have been forgotten and not used very often because of the need to intervene on a fresh stent. I think you've demonstrated very nicely the role of OCT in defining the situation where such a case might be very helpful. And in your case here, this particular situation where there was a huge discordance between the left main and the LAD will make it necessary for you to have very precise placement of the stent. And this, I would say, would be one situation where this technique would be very, very helpful. And with the OCT, and employing the algorithm, you are also able to clarify the morphology and thereby guide you in the strategy in necessary lesion preparation, as well as the choice of the stents that you subsequently use. And you also demonstrated with OCT following the procedure an optimal stent result. So I'll say congratulations, that was an excellent work. And I'll leave to my fellow panelists if they have anything else to add. Good work.
Thanks for the presentation, Adrian, for those comments. In the interest of time, we'll move on to the second presentation from Indonesia by Dr. Nanda. Thanks, Dr. Nanda.
Okay. Can you see my slide?
Please go ahead.
Here. Okay. Okay, thank you. That was ejected. Hello, everyone. My name is Nanda Iriuza from National Cardiovascular Center Harapan Kita. Thank you for the chance presenting our case in this meeting here. And today I would like to share our case, utilization of saline in OCT-guided PCI. Don't have any potential conflict of interest. The case was a 45-year-old male. He had a complaint of shortness of breath during the mild exertion. And he also had a history of inferior ST elevations 2 months ago, complicated with total AV block, and then temporary pacemaker and primary PCI to the RCA was done at that time. And the RCA flow was restored, as can be seen in this right screen. And he was hypertensive. He is an ex-smoker and had a strong family history of coronary heart disease. And echo shown reduced ejection fraction to 42% with anteroseptal hypokinesia. So after 2 months, we brought again the patients to the cath lab since there were lesions at the LAD and the circ as well. And the proximal LAD had a severe diffuse disease with almost 90% of stenosis, while the circ also had multiple tight stenosis from the proximal to distal area. However, due to our insurance constraint, we were primarily focused on the LAD. So therefore, we decided to guide our PCI with OCT as the intracoronary imaging tool because we couldn't identify yet what was the lesion, whether it was calcified or only fibrous or lipidic. And then first, we pre-dilated the LAD with semi-compliant balloon to 0.20 millimeter in order to open the vessel to let the OCT catheter goes into the vessel. So then we performed the pre-OCT. However, we tried to use 20 cc of saline instead of contrast to clear the coronary lumen. And to reduce the risk of suboptimal clearance, we use automatic injector with 400 PSI and speed of 4 cc per second. And we can see here the luminal clearance was good. And then also we can identify the lesion morphology clearly from this OCT run. And as usual, we started from the healthy segment distally. Then we can see here some dissection due to our predilatations, some fibrous and some white and red thrombus with narrowing lumen here. And we're here approaching the left main area. And here is the segmental analysis from the PCI OCT run using the MLD algorithm. The lesion morphology was dominantly consists of fibrolipidic lesions and thrombus. The lesion length was about 33 millimeter from the red arrows to the red arrows here. And the proximal diameter reference was about 3.0 to 3.3, while the distal reference was about 2.5 to 2.7 millimeters. So since the lesions mostly consist of fibrolipidic and thrombus, we were confident not to use any atherectomy device or scoring or a cutting balloon. And we only use 15 along the lesions, and we use the distal reference identified by the OCT stent sizing. So therefore, we use 33 millimeters science expedition stent with GILT balloon technique to preserve the side branch. And finally, we did POT pot with 3015 with NC balloon at the proximal part of the stent. Then again, we evaluate our PCI result with the OCT. And again, we use 20 cc of saline with automatic injector again, 400 PSI, 4 cc per second speed. And the luminal clearance was quite good. There was only minimal suboptimal clearance maybe. And the stent expansion was clearly visualized from this run. And there's only minimal red area in here, maybe the length is quite short here, so we neglect it. And then here's the segmental analysis using the MAX algorithm. There were no medial dissection. The stent was well opposed, and the stent expansion was about 93%, which is optimal here. So we were quite satisfied with the PCI OCT run and did the final angio shot. And the LAD was excellent from proximal to distal part, and no thrombus seen from this angio. And we plan to PCI the circ next if the patient is still symptomatic. So in conclusions, we know that from our case, the utilizations of Saline is possible for OCT-guided PCI, and Saline use in OCT-guided PCI might be beneficial in patients with, for example, renal impairment. And the use of the automatic injector may help to maintain the pressure consistency of Saline to avoid the suboptimal luminal clearance. So that's all from me. Thank you very much.
Thank you very much, Dr. Nanda, for good technique for the media, alternative media for the OCT. And I think you also demonstrate very well how to use the step-by-step on the MLD Max to help finishing the PCI. So let me brief review on what the use of the Saline in OCT guide PCI. I think when you look at the barrier of OCT adoption, apart from the cost reimbursement issue, one thing when you look at advantage, disadvantage between OCT and IVAS is because OCT, you need to use additional contrast. And I think that may be worrisome in some people who have a CKD in high stage. So I think with zero contrast, I have been talking in recently, they have the different media to use instead of contrast. Contrast, as you know, is good for imaging quality, which is very most important for OCT interpretation. But you can also use the dextrans with acceptable image quality. But you may have some concern with anaphylaxis, which occur in 6 in 1,000. And the Saline, because of low viscosity, you might need to get the larger volume and require to use injector, as you have been, Dr. Nanda had demonstrated very well. So I think I pull up to the study and have some study look at the compare between contrast and Saline, and have been shown that for the 20 patients over 10,000 image cross-sectional view, if you look for optimum image quality, that you see very well 360 and acceptable for 270. You can see contrast is actually better compared to Saline. And also with the lumen diameter, Saline appear to be a little bit smaller, but not that significant. But in the case that have the good image quality, using the Saline, I think you can appreciate how you can look in the macrophage, look at the lecanalized thrombus, look at dissection, and also look for the stent optimization as well with the bifurcation. So I think for my practical point, I still prefer using the contrast in the routine case, but with the introduction with the normal Saline as the media, I think in the high-risk case with the CKD, I think this might be a good practice, and especially in the complex PCI that you need to do many runs of the OCT, like calciums, that to look at for stent expansion optimization. I think that will be a good one. Thank you very much. And congratulations, Dr. Nanda.
Congratulations,
you,
both. Very nice images, Dr. Natawut. So we'll now move on to Dr. Munawa from Indonesia.
Thank you, Professor. Let me share my slide first. So good evening, all professors and doctors. It's a really great honor to be here. My name is Diana Sati Munawar, and I'm from Binawalia Cardiac Center, Jakarta, Indonesia. And I'm here to present our case about sequential crush in decay crush technique using OCT guided. So for today's case, we have 64-year-old male with chest discomfort since 2 weeks ago, and he had diabetes and dyslipidemia without history of myocardial infarction. And from his CT scan result, the calcium score is 57 0.7, and then the LAD and diagonal seems like there's a significant stenosis in the proximal part and very diffuse on the diagonal. And from the echo and the lab results showing a good result. So we've done angiography in this case with right distal radial access using Gladstreet cylinder. And then we can see that there's a significant stenosis on the ostial part of the LAD up until mid, and then there's a severe and diffuse lesion on the diagonal too. So from here, as we know that the LAD diagonal bifurcation with Medina 111 lesion with side branch, long and diffuse lesion. So we plan upfront to stent technique using decay crush technique. In this particular case, we use sequential crush, and I will explain about it later on. Then we use OCT guided to optimize our stenting. So firstly, we use our workhorse wire run through hypercoat to the LAD, and we use dual lumen microcatheter with cyan wire to the diagonal too. And then because it's very diffuse and tight, so we upfront using scoring balloon preparation up until proximal part on the diagonal. And this is the result in the OCT run on the LAD. We can see that throughout the lesion is mostly lipidic plaque with some fibrocalcified plaque with thin calcification less than 180 degree. And then especially in the proximal part, we can see that there is a lipid core with tightest lumen area is 1.8 millimeter square. And then the distal part is diameter is 3.2 millimeter and the proximal is 3.7 with lesion length around 36 millimeter. And this is our OCT run in the diagonal. We can see that there's some dissection because of our scoring balloon. And the lesion is mostly lipidic with some calcification. And as you can see here, the diameter in distal part is 2.3 millimeter, and the proximal part is 2.6 millimeter with lesion length around 28 millimeter. So from here, we start the preparation using scoring balloon in the diagonal with 2.0 balloon. Then we use scoring balloon 3.0. Because of the OCT result, we don't use any atherectomy, only scoring balloon up until proximal part. So next we move on to the stenting technique. We use decay crush technique with sequential crush. Firstly, we did stenting in the side branch. We use DS 2.530 millimeter stent in the diagonal. Then we crush it firstly with the distal main vessel as a diameter as a reference. We use 3.0 millimeter balloon. Then we crush it. Following with proximal main vessel diameter as a reference, we use 3.5 millimeter balloon, just like a pot balloon in the proximal bifurcation of LAD and diagonal. So why we use sequential crush? Because usually the balloon we use for complete crush is according to the distal main vessel. However, there's a gap between the stent strut and the lumen wall. So that's why we use the pot balloon using a proximal main vessel reference balloon size to prevent the wire recross behind the strut of the crush stent. So firstly, we continue with the technique, and then we do a first recrossing into the proximal strut. And then we make sure the strut is going to the proximal. We did a OCT run. As we can see here, we know exactly that our wire is going through exactly at the proximal part from the 3D rendered picture and also from the longitudinal view. And we can see here from the 3D also the stent crush after we use a sequential crush is very in the lumen wall, and the wire is not in between of the lumen wall and the stent strut. And you can also on the axial run. So after we confirm that the wire goes to the proximal, we follow with first kissing balloon using 2.5 and 3 millimeter balloon. Then we put stent 3.0 36 millimeter stent in the main vessel in the LAD. Then we did pot with 3.5 millimeter balloon. We can confirm it by using the stent boost technique up until proximal part. Then we did another recrossing, the second recrossing using dual lumen catheter and cyan wire to the mid or distal strut. So after we cross into the mid or distal strut, we confirm it whether we go into the mid or distal part. So we use OCT run again, and we see that the wire goes into the distal strut of the lumen, as we see from the 3D render and the longitudinal view. So after we confirm it, we follow with final casing balloon using 2.5 and 3.0 millimeter balloon, then following with report on the proximal part of the LAD until proximal part with 3.5 balloon. And this is the final OCT run in this case. As you can see, there is no edge dissection. The position is quite good. And then the expansion is 90%, quite acceptable. And the lumen area is around 5 until 8 millimeters square. So that's quite good, with some protrusion on the proximal part. But it's very small, so we consider it not significant. But the most important thing that from OCT, we can see that the side branch is very good and quite and still open on the ostial part. So this is the final angio result in our case. So from here, as a summary, the elective two-stent strategies may be considered for long side branch lesion or high risk of side branch compromise. And DK cross is a valuable option for complex bifurcation lesion, and sequential cross is an essential step in DK cross to prevent wire goes behind strut while we cross. And intravascular imaging guidance is strongly recommended for optimal procedural result, especially in complex bifurcation lesion. Thank you very much for your attention.
Okay, thank you, Dr. Monara. So I think it's really a tough job for her to put all the important information just within the 7 minutes. Maybe I just pull up my slide. Just a quick recap. I think she really able to illustrate how bifurcation standing. I think most of us. Okay, you can hear me? Yeah.
Yeah, I can hear you. Alan, can't see your slides at the moment, I think. Yeah.
I think I encountered some
yeah, I think Alan,
sorry. Yes.
Yeah, maybe try again.
Yeah, I'm coming. Maybe I think time is limited, so I just recap about the slide. So I think very key important, she able to clearly demonstrate how useful is OCT in guiding bifurcation lesion, in particularly how it can, particularly in 3D wiring. I think is the only modality nowadays, the 3D OCT function can enable us to show where the side branch right goes. The other modality like IFS or 2D OCT cannot really tell exactly whether it's a proximal, mid, or distal stent thrust. I think it's very important, particularly when doing meticulous the two-stent techniques. So the 3D OCT, I think she clearly illustrated how you can avoid you go into in appropriate positions, like, for example, proximal cell thrust before you're doing a final kissing. And many reports have shown that you will result in a metastatic carina, which in long terms may have potential problems like thrombus formations in network stent apposition. So I think I need to congratulate her for the very excellent talk.
Thanks, Alan. Congratulations to both as well. And sorry about the technical hiccup. We'll now move on to Malaysia for his OCT presentation. Dr. Lee, please.
Hello, good evening. It's a great honor for me to share my case with everyone here today. So I'll jump right into it. I have a 71-year-old patient with background diabetes, dyslipidemia, and hypertension, presenting essentially with a non-ST elevation MI. As you can see, ECG ST depressions in V2 to V5 with typical chest pain and high sensitive cardiac troponin of 125. Our cutoff in our center is 40. The echo shows a hypokinesia at the anterior basal and to the apical segment. So we perform an invasive coronary angiogram. As you can see here, there's a CTO of the mid-circ with normal left main And in the LED, you can see it's very calcified and tortuous, and there's a tight lesion in the mid and proximal LED. The RCA, fortunately, was essentially mild disease. And here I've included some still images just to highlight the area where it's the tightest area pointed out by the red arrow, and there's area of significant tortuosity distally pointed by the yellow lines. And here you can see, even prior to contrast injection, the amount of calcium that is situated in the mid portion of the LED. So the revascularization strategy was discussed with the patient, and we gave her the option for CABG given the heavy calcium, but she had already preemptively declined open heart surgery. So thus we decided to proceed with PCI with the use of intracoronary imaging, given the heavy calcium burden as seen on angiography, and we decided to use OCT as our imaging modality to assess the depth of calcified plaque. However, we were unable to pass the OCT catheter down due to the tight calcified lesion and tortuosities, and thus we proceeded with pre-dilatation. We used a 2.5 mm NC balloon, and you can see, I guess initially we tried our luck with a bigger balloon and we couldn't fully dilate, especially the distal and mid part. You can see on the yellow and blue arrows indentations on the balloon, indicating that the balloon couldn't fully open. But it was good enough to allow us to pass the OCT. And you can see here the OCT run. I hope the run is smooth from the distal normal vessel to the mid and to the proximal. You can see how heavily calcified it is. There are some dissections, most likely caused by our prior ballooning. So going on to the details of the OCT, the MLD. So the M is definitely a calcified lesion. The length measured was 49 millimeters, and the diameter was distal 2.75 and proximal 3.55. And although we don't have co-registration, I did it manually in my center. Here we can see the distal part, the distal type lesion is very eccentric. That's why you see in the cranial view, it doesn't look so bad, but on the OCT it's actually quite tight with MLA of 1.9 and eccentric calcium. At the yellow area, the yellow line, that is actually, interestingly, a rather small calcified nodule protruding into the lumen. And more proximally, we can see the areas of multiple areas of superficial calcium, as you can see pointed by the green arrow, as well as the area of dissection from the prior ballooning. So in view of the significant calcium burden, as the OCT calcium score was already 4, we decided to perform intravascular lithotripsy. Traditional methods of arthrectomy were not done due to the presence of dissection. It didn't feel comfortable causing a problem. So this was the IVL. We used the IVL shockwave balloon, as it's the only one available right now. We used a 3O balloon, and you can see here it's actually delivering the pulses in the distal part, in the mid and distal part. We delivered about 10 pulses each, and we're quite happy to see that the balloon opened. Now, as we were delivering the IVL pulses in the most distal part, I want you to pay close attention to what's going on. As we're delivering the 48 pulse, we see contrast extravasation coming out from the balloon extending distally. The patient became symptomatic with severe chest pain and transient hypotension. We immediately took a very gentle angiogram to prove that there was no perforation, but instead it showed there was contrast-filled spiral type E dissection extending distally. I've just blown up the angio of the balloon rupturing, as we were able to capture it on fluoroscopy, just to show you again how an IVL balloon can rupture and how it looks like. So the management of coronary artery dissection after lithotripsy balloon rupture. First thing, pain relief medicine was given. I ordered it and for the nurse to give, and an immediate angiogram to rule out perforation. An immediate bedside echocardiogram to check for pericardial effusion was also performed. Fortunately, there was none. We did consider OCT to have a better picture, but we deferred it as a forceful contrast injection might actually propagate the dissection further. So as all cases of dissection, quick stenting was decided. We quickly stented over distally and proximally with 2 stents. We decided to use 2 stents given the tortuosity and the calcium. A 28 times 275 mm stent distally and a 3O times 28 mm stent proximally. Now, we actually used a stent which was longer than our initial MLD because the length was only 49, but you can see here it's clearly more because we knew that the dissection extended further distally. And as such, also we used a smaller stent distally. So this was the angiogram after the stent. Fortunately, no more dissection, and you can see actually the angiographic images look quite good. Of course, there was pinching of the diagonal ostium, but the TIMI3 flow, we decided not to perform any further intervention at this point of time. So this was the post-PCI OCT. So using the MAX, we looked at medial dissections. You can see here, I'll just restart the OCT run. We landed a very nice, healthy distal area, and there was no distal edge dissection, so no medial dissection. The stent apposition, there was some actually malapose struts at the proximal segment. And there was a bit of under-expansion there as well. I can see expansion only 75%. But I want to just show you and highlight a few still images at the proximal segment where the calcium was the heaviest. You can see actually calcified cracks, within the calcium, as pointed out by blue arrow, and the stent has expanded. And more interestingly, at the distal segment, you can see the stent quite well expanded, and you can see in the red arrows the dissection flap that has been closed off by the stent. You notice how extensive the dissection is, about 180 degrees, indicating the amount of damage that has been done actually. So given the under-expansion and the poor apposition, we use an NC35, 16 and 20 atmospheres of post-dilatation proximally. The patient recovered well from the event, but suffered a periprocedural MI with troponins rising 940. Good news is at 1 month follow-up, she is well and asymptomatic, NIOJ class 1 and CCS class 0, and as such, we elected not to perform PCI on the CTO of the circumflex. So a few points for discussion. The worldwide adoption for IVL continues to increase due to the low rates of complication and perceived short learning curve. As such, it's a form of paradise amongst new interventionalists, especially those with limited experience performing arthrectomy, hence the title of my talk, Trouble in Paradise. However, sporadic cases of complication are beginning to emerge. IVL can cause coronary artery dissection when the balloon ruptures, and the immediate management of artery dissection after IVL balloon is vital to prevent morbidity and mortality. Now, the pathophysiology behind this occurrence is still not well known, but there are some specific anatomical characteristics that might predispose. Of course, these are all theoretical and have not been proven in randomized studies. In some case, so in this case, we pinpoint 3 possible causes. One is the luminary protruding nodular calcium. Second is the significant tortuosity of the coronary calcified lesion. And thirdly, possible gaps between the balloon and luminal wall caused by either the above 2 features. So there's such, I think the take-home message from my presentation is that precise intravascular imaging prior to the choice of calcium modification is vital to avoid risk of complications. Not all calcified plaques are the same. With that, I would like to say thank you.
Okay. Great talk. So this is my duty to comment your slides. I learned so many things from your slide, Dr. Lee. So okay, hopefully you can see my slide. It's okay, Jack?
Yeah, it's good. Go ahead.
Okay, all right. So anyway, again, thank you very much for your case. I learned so many things from your case, Dr. Lee. So anyway, this is my first slide. I understand that you all, already published your case in the European Heart Journal. So I think it's going to be a big point for him, right, Jack? So I learned many things from this case. So anyway, back to your case, and then if you remind for the algorithm, if you could pass your OCT catheter, you can treat the calcium accordingly. If you have, let's say, the arch more than 180, and then the thickness and then the length for more than 5, and you can cross your balloon, so the IVL may be the best option if you have an IVL. If you cannot, so maybe orbital or rotational atherectomy will be the option. But the problem in your case, I think, is that you're in the first place, you cannot cross your catheter. So this is uncrossable lesion due to the high calcification. So the option will be, should we direct go for rotational atherectomy or orbital, or you like your choice, you do a dilatation, pre-dilatation first, and then go for your OCT catheter. But for me, maybe to open up with 2.5 a little bit too aggressive for me. But anyway, you choose that. I appreciate that. because if you choose that in that situation, so that's why, and beautifully you can show us that you created some dissection. So there will be a limited option after that. So maybe IVL will be the only option if you face this kind of condition. So in my country we don't have IVL. So maybe if I face the condition that you have, so I will go for orbital or rotational atherectomy in the first place. But anyway, you did a terrific job. You did seal the dissection, and then we also learned MLD Max, also showing a very nice result from your case. Anyway, that's all my slide, Jack. Thank you very much.
Thanks both again. Both very nice presented. We'll now go on to Dr. Kwa Lee from Singapore to state his case.
Okay, very good afternoon to everyone. So let me just make it full screen. Yeah, so thanks to APSC for accepting my case submission for this OCT competition. My name is Giulio. I'm an interventional cardiologist from Ong Cheng Fong Hospital, Singapore. And I'll be presenting a quite simple and straightforward case, but which I thought was quite interesting and unusual. And the topic of my case is unusual OCT imaging in spontaneous coronary artery dissection. So my patient is a 57-year-old female. She's non-smoker. She has a history of schizoaffective disorder and Parkinson's disease. So she presented with symptoms of crushing chest pain for the past 4 days, which was worse on exertion. Cardiovascular risk factor screening was unremarkable. And her first troponin was elevated at a level 126, and the subsequent came up to a level 313. ECG was quite unremarkable other than some non-specific T inversions in B3 to B6. Echocardiogram was also quite normal with a normal systolic function with no regional wall motion abnormalities. So at that time, the working diagnosis was that of NSTEMI, and coronary angiogram was performed. So circumflex, as you can see here, is quite normal. And in the AP cranial view, you can see that the distal LED here is occluded. Okay, so the right coronary artery also is quite unremarkable. So I proceeded to wire the lesion. So it proved a little bit challenging, and I required a hydrophilic wire mounted on a microcatheter. The lesion was actually quite tortuous while crossing it. And what happened was, after crossing the lesion, what you can see here is there was actually recanalization with establishment of flow. So based on this angiogram, perhaps you can already make a diagnosis of SCAD, but because the wiring was actually really quite tortuous, so I was a bit concerned about accordion phenomenon. The second reason also that the lady was 56. So as you know, SCAD usually falls into a younger age category below 50. So I just wanted to perform OCT to confirm my diagnosis. So this was what happened. So as I placed the OCT catheter distally within the lesion, when I went to the live view, I realized that my wire and my catheter was actually in the false lumen. And you can see here the true lumen, which was being compressed at the 9 o'clock position. So I've illustrated this with a still image as well at the side to show where the compressed true lumen was. So at this point in time, I decided to use a stationary mode for image acquisition to capture this. And then as I put the catheter back more proximally, and I went live again, and then now what you can see here is something quite different. So now you can see that the wire and catheter was actually now in the true lumen, but surrounding the true lumen is actually the hematoma. So again, I have illustrated this with the illustration on the right. And actually towards the end of the acquisition, you can notice that I give a little path of contrast just to light up the lumen. So you can see where the true lumen is and the hematoma that's surrounding it. So again, I use a stationary mode to obtain this image acquisition. So this is just an illustration of what I think happened. So the proximal bit, you can, it's probably where the hematoma was actually compressing on the lumen and therefore occluding flow. And as I wire the lesion, with the microcatheter, that kind of re-establish or rather establish a bit more luminal gain, and therefore help to establish some flow across the vessel. And then, as you can see here, my wire probably went distally into the dissection entry point, and therefore, when my OCT catheter was there in the distal segment, it was actually in the false lumen, and the hematoma probably propagated retrogradely and with compression on the lumen as shown on the second OCT run. So this is the final angiogram. So because the patient was asymptomatic, hemodynamically stable, and I established TIMI3 flow, I did not do anything. But what you can see here now, distal to the lesion is also the radiolucent lines, which are very pathognomonic of SCAD. So this is just a quick recollection of the 3 different types of SCAD. So we know that in our patient, we had a long diffuse narrowing, which is very typical of type 2 SCAD, which is due to a hematoma compression. And then we also have features of a type 1 SCAD, which is the radiolucent lumens due to your dissection plates, which was seen in the lesion, distal to the lesion in my patient. And then type 3 is the rarest form, which actually mimics the atherosclerosis. So she was advised to get a CT scan to evaluate for extracoronary arteriopathies, but the patient declined. Then she was seen in the clinic on the 9th of February. She was well asymptomatic. So some learning points. So we have to remember that contrast injection may potentially propagate the dissection plane in patients with SCAD. So you need to exercise caution when performing OCT. So you can actually make use of non-contrast OCT imaging. It's a very good way to obtain diagnostic images as well. And thirdly, stationary mode recordings are useful to evaluate coronary artery lesions at focal sites. Okay, with that, thank you for your time.
Thanks.
Okay, thank you very much. Yes, I will share my slide. Can you see my slide?
Yes, please go ahead. Full screen. If you can go. Yeah, thank you.
Yeah, sure. Thank you very much, Dr. Kaur. It's a great case for the OCT imaging in SCAD. So as you said, the angiography has a limited ability to diagnose a SCAD. However, OCT has a high ability to identify disrupted intimal disruption, false lumen, and hematoma. And this slide shows the ASST guideline for management of SCAD. The use of OCT is recommended to guide the optimal treatment for SCAD. And this slide shows the OCT assessment of guide wire location. Left panel shows the guide wire in true lumen. And as shown in the left panel, 7 o'clock, and medial is seen. So lower lumen is true, and the upper lumen is false. And as shown in the right panel, the guide wire in the false lumen. And the medial is seen in the 11 o'clock. So upper lumen is true, and the lower lumen is false. So OCT gives us a very clear image. However, there is a concern about the intracoronary pressure increase during OCT imaging. We measured a pressure increase using the FF4 pressure wire during OCT imaging and contrast injection. So during contrast injection, intracoronary pressure was increased up to 10 millimercury. So authors afraid the expand of the SCAD during OCT imaging. So authors used non-contrast OCT imaging in SCAD. The left panel, OCT guide wire in true lumen, and the right panel, OCT visualized clearly. True lumen is at 7 o'clock, and wire is false lumen. This is a summary of the author's case. And the angiography and the OCT demonstrated SCAD. And a non-contrast OCT clearly demonstrated guide wire in the fourth lumen, high risk of coronary occlusion by stenting, and obstructive but normal coronary flow. So the authors selected optimal medical therapy without deferral of PCI, and he achieved spontaneous hearing. So this is a teaching point, and the use of OCT should be considered to guide the optimal treatment for SCAD. Non-contrast OCT is a safe method in SCAD and can provide acceptable images. Physicians should ensure that the guide wire is in the true lumen by OCT prior to PCI to avoid the complications of coronary occlusion associated with the stent implantation. Thank you very much, and
Thanks.
congratulations.
Thanks, a great presentation, great comments. Actually, I really like that. So now we'll move on to the next presenter from Taiwan, Dr. Liu, and I'll ask for the presenter to keep to 7 minutes strictly. Thanks, Dr. Liu. Are you able to go to full screen? Yeah, good. Please proceed. Can you unmute yourself first as well?
Yep.
Thanks.
Okay, I'm going to share 5 years OCT follow-up in patients with previous stents. Here's my key learning. First, in OCT in pre-intervention guidance, it helped with good morphology and helped reset strategy. And in stent implantation, it helped with guidance of stent implantation and maybe detect the intraoperative complication. And third, in surveillance, and as BVS or ultrathin stent that can be hard to see in the angiogram, so OCT is suitable. And here is my presentation. 56-year-old man with hypertension, type 2 diabetes, and COPD. His coronary history with 2006 with Zabo angina, angiogram showed 2 vessel disease. He was treated with 3 BMS stent, 2 RCA, and 1 separate stent to meet LAD. Another major cardiovascular event happened in 2016, and angiogram showed left main and 2 vessel disease. RCA was treated with BVS stent and BMS stent, and LAD was treated with stage PCI with OCT image. And we can see the OCT, and we can see the stage PCI. And for right side, as BVS stent, there is no instant restenosis. For left side, we can see that men with disease with diffuse ISR over LAD. The significant lesion was shown at the right side, and I'm going to check the OCT. OCT was divided into 2 parts, and we can see the distal part. Distal part, we can see the septal stent was very clearly seen, and we can see a huge, significant instant restenosis. And we can also see some calcified lesion outside the septal stent. The septal stent size was about 3.0 millimeter. For the next part, we can still see the significant instant restenosis of the septal stent, and here it comes the proximal LAD. Proximal LAD, there we can see the huge calcified burden, and the huge calcified burden is extended to osteo LAD and even to the distal left main. For the POC evaluation, we use MELT. Morphology, diffuse instant intima hyperplasia and calcified and fibrous plaque at the proximal LAD to left main. Length is about 60 to 70 millimeter. Diameter, distal is 2.5, middle 3.0, osteo to proximal to osteo is 3.5. Left main is over 4.0. He was treated with 3 BVS stent. The BVS stent localization was illustrated at the right side, and distal 2 stents were overlapped, and proximal is from left main to proximal LAD. And the previous Zabo stent was treated with DEB. And we're going to check after proper preservation, we check the OCT again. So we can show some, here comes the BVS, and there is no significant edge dissection. Here comes the overlap zone. And so we can see the stent was in proper expansion and opposition. And from the middle part, we can see some tissue protruding over here. And so here comes the previous sample scan to BMS, and the size was okay, and the proximal stent. The proximal stent was in proper expansion and the position, but in distal left main, the size was relatively huge, so there is some malopposition was noted. For a post-OCT, we use MAX. Medial dissection, there is no significant edge dissection, but we can show some intra-stent dissection. Opposition, left main stent is showed malopposition. Expansion, all include expansion. So we use larger NC balloon to both dilate the left main stent and to check the OCT again. So the OCT image was shown in proper position, and we can see the final angiogram. Then patient was regularly followed at our outpatient clinic and with optimal medication. The next event happened at 2017 with angina. The LAD showed mild in-stent restenosis, and RCA showed in-stent restenosis as well. So middle LAD was treated with DEB, and RCA was treated with angioplasty. Another event happened in 2021, and nuclear imaging showed reversible malperfusion defects. So he was admitted for another coronary angiogram. For right side image, there is no significant in-stent restenosis. For left side, and we can show there is no significant in-stent restenosis, but it was hard to see where the BVS or previous stent is. So we check the OCT again. In this OCT, we started from the limbal part. You can see the previous stent localization. And in previous BVS stent, we can see all fully resolvable BVS stent. And there is sustained lumen size in this stent. And here comes the previous DAB zone is also inadequate lumen size. Here comes the proximal to LAD BVS. And it's also see that no significant restenosis and fully resolved BVS. And even larger lumen size can be noted. So compared with the previous 2006 OCT, and it showed no in-stent restenosis and fully absorbed the scaffold, and it's likely positive remodeling of the BVS. Thank you for your attention.
So thank you very much for that wonderful demonstration of OCT. And I think that as a technology, it's a shame that the BVS is not available much anymore internationally, and that the history of that BVS technology has been mirrored with the OCT because it told us so much about how BVS behaved, particularly that it dissolves. It might take a long time, like 5 years, as illustrated in this case. And of course, I think I really like the idea that you're sizing and understanding what's happening in the coronary artery with the ISR. And diffuse ISR is very difficult to treat. So it's also illustrative of what's happened with the time frame. You even try to use the BVS for in-stent restenosis, and then had to use drug-eluting balloons, which is kind of a mainstay of what we're doing now. Although imaging, we need to find out the mechanism of why the ISR, is it undersized stents? Is it just failure of the drugs? And essentially understanding how to treat that and characterizing that is very useful. So I really appreciate that. It's a lovely case. And of course, I think in my experience, IVUS really had a lot of artifact once your scaffold is in, and OCT was so much clearer seeing the bricks, and also if you follow them up, seeing them dissolve as in this case. And also I like that positive modeling. That was also what we found with OCT studies in the original cohort. So thank you very much for that case.
Thanks, Sydney, and thanks for keeping the time. So last but not least, we have Thailand. Dr. Sakawat, your last chance.
Okay. Good evening, everyone. My name is Dr. Sakonwat Montraiwait from the Police General Hospital, Bangkok, Thailand. It's my honor to present my case entitled OCT Guided PCI of a calcified lesion with large luminal diameter. My case is a 64-year-old man with hypertension, dyslipidemia, who presented with dyspnea on exertion. From echocardiogram, he had reduced LVEF and hypokinesis of anterior and inferior wall. Coronary angiography revealed a 3-vessel disease for which PCI of mid-RCA was successfully performed, and he was brought for stage FFR and possible PCI of LAD and OM branch. This is the angiography of the left coronary system. As you can see in the cranial veil, we have an intermediate stenosis of proximal to mid LAD and distal LAD. And also at the bifurcation of LAD and DG, we have a DG1 lesion as well. For the caudal veil, we have an intermediate stenosis of OM. So we proceeded with an FFR and RFR, and it revealed positive result for LAD and DG1. And the pressure gradient was positive for both proximal and distal LAD lesion. For the OM, it was negative. So my plans was to use a radial approach. Guiding was SB 3.5 6 French. And plan to treat distal LAD first and then perform the complex PCI bifurcation lesion at the proximal LAD and DG1 using 2-stent technique and also an OCT guidance. This is the OCT run of the mid and proximal LAD. As you can see, we have a heavily calcified lesion at the mid and proximal LAD at the bifurcation lesion. And also at the proximal LAD, we have a very large lumen up to 3.5 millimeter. For the MLD max, the distal reference for the mid LAD lesion, we have EL of 3.0 millimeter. And the narrowest part is had a near circumferential calcium plaque with MLD of only 1.9 millimeter. For the proximal reference, we have EL of 3.5. So in this case, we have to do something about this calcium lesion. And also, if we plan to stent, we should use a 3.0 millimeter and then post-dilate the proximal reference up to 3.5. If you take a look at the OCT best calcium score, as you can see, we have a near circumferential calcium, very thick and long calcium plaque. So how do we treat this lesion? Do we just use a high pressure NC balloon, focus the force using scoring balloon, or use rotational atherectomy? But in this case, the vessel is too large, so we need a larger burr. So we need to switch to 7 Frenchies to use a more than 1.75 burr. Orbital atherectomy and the lithotripsy, we don't have that in Thailand yet. So in this case, we're going to use rota. First, I treat distal LAD first with 2.5 stent and perform rotational atherectomy at the proximal and mid LAD lesion. In this case, I use a 1.5 millimeter burr and first do LOTA with high speed at 180,000 RPM, and then again use 1.5 millimeter at low speed at 120,000 RPM for more luminal gain. This is the OCT result after rotablation. As you can see, we have snowman appearance and also thinning of the calcium sheet. However, the calcium still did not fracture yet. So in this case, it's not optimal preparation. So I use NSE scoring balloon 3.0 to further predilate the calcium lesion up to 3.0. And then again, use the OCT to check for lesion preparation. In this case, we have a media tear on the upper hand side. And on the lower image, we have 3 intimal tears in accordance with the nylon string of the NSE balloon. So we have an optimal lesion preparation now. And I proceed with the decay crush. In this case, I use the side branch stent of 2.25 millimeter and the main branch stent of 3.0 as in accordance with the distal reference of 3.0. And I perform decay crush as in the classical fashion using pot KBI, repot again, and aim to post-dilate the main branch the proximal portion up to 3.5 in accordance with the proximal reference from OCT. This is the final OCT result. As you can see, the stent, this is the mid and proximal LVD stent run. There was no major edge dissection, and the apposition is acceptable with less than 300 micron. We have a very acceptable minimal stent area of more than 100% expansion. And also, if we take a look at the LAD and DG carina, we have a fully opened and covered DG ostium. Okay. So my learning points from this case is that OCT is a very valuable tool for PCI planning and evaluation, especially if we use MLD mass protocol. We can choose the balloon for pleat dilation and choose stent size very accurately using OCT. And for the heavily calcified lesion with large luminal diameter, we can overcome it with using combined high-speed and low-speed rotational atherectomy and scoring balloon. And lastly, DK crush is an excellent two-stent strategy for PCI of the complex bifurcation lesion. Thank you.
Can you see my screen?
Hello, everyone. My name is Dr. Sakonwat Mondraiwait.
Not yet, though. Can't see your screen. Maybe you can speak to it, Dr. G, in the interest of time.
Okay. Okay, let me see. Sorry, can you see something? No. Okay, wait. Can you hear me?
Yeah, I can hear you clearly.
Okay.
Dr. G, maybe you can just speak to it.
Okay, very excellent example of the use of the strategy. The use of the strategy starting on what? Essential point, calcium. Calcium is not suitable for making a nice assessment of the lesion. We have a clear evidence that we must use a different type of assessment, physiology and imaging, that were used both in this case for assess the severity of the lesion and decide which one, diagonal and LAD, and then for guidance. Then we had the evaluation of how to decide. It was using a score, taking all these different aspects and going to the reality, say that I can use different tools, but in fact, in my hands, I do not have some of them, like lithotripsy, and so he switched to rotational atherectomy. He had this great assessment with the rotational atherectomy at a different speed based upon the literature, where when you have a large lumen and you want to gain more, you can slow down the numbers of runs during the rotational atherectomy. Then he was assessing the lesion by using imaging OCT. He said, I thin the calcium, but I still do not have evidence of incision, fraction. And then he decided to add a more aggressive lesion preparation by using scoring. He got all these points and he was end up with a large lumen. If I can make a few additional comments, the first one is to finish, it should be nice to have, when you are DK crush involving big bifurcation, also some view by using the 3D. And the final comment is to everyone, it was a great session with a beautiful case presented by younger people. I'm so in trouble to say which one is the best or the second, because the quality was really very, very high. Extremely happy to have shared the time with you guys.
Thanks, I appreciate those comments. I'm going to prepare the results to announce in 2 minutes. Before I do, I'm going to ask Sydney and Takashi to make also their final closing teaching remarks, so I get some time. So Sydney, please.
So look, I think that all the cases demonstrate this, the younger generation moving forwards. And I think that it's part and parcel of your PCI, because you got to do the imaging. And the key thing is pre-interventional imaging, so you can assess and plan and then deliver a good result. MLD max, they're very simple algorithm, morphology, the lesion length, sizing your stents, and then delivering the stent and dilating it well. Less work on the back end, optimizing also the stent expansion and looking at the medial dissection, edge dissections that you may need to cover. That minimizes your adverse events, optimizing your stent results. So I think that's it's a very simple thing to follow. And I think that, but the little proviso, if you're doing lithotripsy, you need to check the adequacy of that in the middle before you put the stent in. But other than that, I think it's been a great demonstration of all those techniques and getting good images. So I really enjoy the talk from Dr. G, as well as all the cases.
Thanks, Takashi.
Yes, thank you, everyone. I really enjoyed this session. All you gave us a very wonderful case presentation and lectures. Actually, there was a lot of learning points. And also, I would like to say thank you, Dr. Jack Tan, for giving us a very important opportunity. I learned a lot from this session. And finally, I hope you all use the knowledge that we learned in this session in your daily clinical practice. Thank you, everyone. Thank you very much.
Thank you. I'd like to echo all the points by my last three panelists. And I just like to put a note there that there are actually a lot of cases that we didn't select to present here that was also fantastic. And I'm also reaching out to those people that submitted with great cases. Particularly, we had a lot of submission from Indonesia. Sorry, I couldn't put all the Indonesian cases here. We had to create a separate Indonesian session just to do that. And I'm going to put them up as claps subsequently. So now it's time for results. Everyone is a winner, but they are a judging panel. And I also like to again thank all my judges who spend time to handpick the best cases and also to give their grades. So without further ado, these are the results. So thanks, Dr. Nanda, and thanks, Dr. Munawa. Great cases. Thanks, Dr. Kwajeli from Singapore as well. I really like that imaging on SCAD. And also thanks to Dr. Liu. I haven't seen the VUS for a while. Presenter? Yes, thank you, Dr. Salawat from Thailand. Very nicely presented. We have Dr. Rashid. Okay. Sorry, I must have kept you in suspense because my internet crashed. So
okay. Keep us excited.
Yeah, keep you excited. I don't know whether you saw the second prize, but the winner I'm going to announce.
Not yet, not yet.
So I have to go back again then. So our first runner-up, just in case you drop out, was Dr. Rashid from Australia, presenting OCT-guided Zabo technique. And our third prize placement was our last presenter, Dr. Sokawat from Thailand, on the OCT-guided PCI of a calcified lesion, very well demonstrated. So congratulations. And our winner for today don't tell me I crash again. It's Dr. Lee from Malaysia, Trouble in Paradise. So we really enjoyed his case as well, and the judges gave him the highest score. So congratulations, everyone, and thank you for today's session. Sorry, overrun by a bit, but thank you for all the speakers, and special thanks to my panelists who spent so much time before today on this session. Thank you much, and keep safe, and goodbye. Bye-bye.
Bye-bye.
Thank you. Bye-bye.
Thank you.
Like the session. Thank you.
Bye-bye.